The clinical case discussion today is based on a child presenting with diarrhea and vomiting. The objectives of this clinical case discussion is to go through the assessment of dehydration, differentiation between viral and bacterial gastroenteritis, non-enteric causes of diarrhea in young children, and management of dehydration.
Okay, right. So this is the basic details of the patient. Tarushi is a 13-year-old girl who is currently in our ward. She presented with fever of 5 days duration and difficulty in walking for 3 days. She also developed painful swelling of both ankle joints for 3 days and then pain in right thumb for 1 day. She also complains of difficulty in opening the mouth for 1 day duration. So these are the symptoms or the complaints that this girl had on admission. Now, if you were the first contact doctor, okay, if you are the first contact doctor who's going to see this child, what are the possibilities that cross your mind or that comes to your mind? Can
JIA.
you? Okay, JIA. What type of JIA?
Polyarticular.
Okay, right. So you think of polyarticular JIA, right? Very good. Anything else? What do others think?
Reactive arthritis.
Okay, very good. Anything else? I would like to have about 4 possibilities for this presentation.
Systemic onset JIA.
Okay, systemic onset JIA, good. Okay, one more. Okay, so for the moment, we have reactive arthritis, polyarticular JIA, and systemic onset JIA. Now, to build up your history, now in your initial history taking, you ask a direct question from the mother, isn't it? Now here, since the child is 13 years, you can take the history from both the mother and the child. So you will pose a direct question, an open question to them. So they will go on telling the story, right? So you will get the evolution of the symptoms as an answer to your open question, right? And then you need to formulate your differential diagnosis and then make your direct questioning to narrow down your clinical diagnosis, right? So that is how you get about this. Right, so this is a previously well child, right? She never had any joint problems. So this is the first time she is coming to the hospital. So any other thoughts that this could be? Okay. Right. So now the possibilities point of view, this could be a reactive arthritis, which is usually a post-infective phenomenon. Can you tell me, few causes of reactive arthritis at this age?
Viral infections.
Very good. One more.
History of dysentery. GI infections like salmonella.
Yeah, very good. Yeah, GI infections. Right. Okay. Right. So I will, give you a list of possibilities. Actually, yeah, the commonest cause for fever and polyarthritis of acute onset is reactive or post-infective due to viral or bacterial. And then secondly, because of this multiple joint involvement, you need to think of autoimmune conditions like polyarticular JIA. And also, given the age of this child, a 13-year-old girl, you need to think of SLE as well. Right? So this could be the first manifestation of SLE. Right? And could this be rheumatic fever? Likely or unlikely? It's unlikely because of the involvement of which joint? Why is she unable to open her mouth?
Temporomandibular joint.
Yeah, it's because of the TMJ involvement. Generally, in rheumatic fever, there is no TMJ involvement. So, rheumatic fever is a bit unlikely if she really has TMJ involvement. We haven't elicited in our examination yet, right? Okay, right. Could this be an acute infection which is associated with polyarthritis? Rather than this being a post-infective phenomenon, could this be an acute infection which is associated with polyarthritis?
Since she's having a fever, it could
Yeah.
be, madam.
Yes, it could be. Right? Okay, right. So we'll go through the list of possibilities. Right. So reactive or post-infective are both, both refer to the same thing. Arthritis is one of the main possibilities. Okay. Acute rheumatic fever, you need to consider until you examine this child and establish this TMJ involvement, because any girl in our, in our community, we need to consider acute rheumatic fever. But however, if you confirm your TMJ involvement, you may discard this possibility. Then any acute infection with polyarthritis, like infective endocarditis, mycoplasma, and also rickettsial infections are possible. And then, as you all mentioned, autoimmune disorders, SLE. This could be the first symptoms of rheumatoid arthritis, the adult type. She's 13 years to develop juvenile idiopathic arthritis now. And also dermatomyositis is also a possibility. And finally, you need to consider malignancies as well. Children can present with polyarthritis, with leukemias, and also neuroblastomas. She is a bit too old for a neuroblastoma, though. Okay, now, if you at least consider 3 or 4 differential diagnoses out of this list, then you need to make your direct questioning to make a proper systemic inquiry to narrow down further the list of your differential diagnoses. Okay. Right. So what else would you like to know from this child and the mother? Okay. So firstly, you need to find out the evolution of the symptoms. Now, the main symptoms in this girl are, number 1, fever. So it's just a 5-day history of fever. So you need to ask day-to-day progression of the fever. What time did she have the fever? Was it intermittent? Was it remittent, continuous? What type of a fever? It's important to find out what sort of a fever she had. In autoimmune conditions, like, if it's a JIA, she may have high, it's difficult to say since it is just 5 days, but whether it's low-grade fever or high-grade fever, right? In in an acute infection, like infective endocarditis, she may have very high spiking fevers, whereas in SLE or rheumatoid arthritis may be just a prolonged low-grade fever also. So anyway, you need to analyze the fever and the joint symptoms, the evolution from the onset, which joint did it start, whether there was any flitting type of arthritis like migrating, the degree of involvement of the joints, what was her disability, whether she could move about with her arthritis, the functional disability she developed, right? The degree of pain. So all those things you need to find out regarding the evolution of the illness. And then you need to take a focused history to narrow down the differential diagnosis, considering each and every possibility you considered in the list of your differential diagnosis. Okay, so we already talked about this. You analyze the fever, arthritis, the general condition of the child, like what happened to her appetite, any associated symptoms like nausea, vomiting, abdominal pain, things like that. Okay. Then your systemic inquiry focuses on the differential diagnosis. Now, what are you going to ask to elicit whether she had the reactive arthritis? So what will you ask from the child or the mother to find out whether this is a possible reactive arthritis? Tell me one or two questions that you will ask.
Recent history of vomiting and diarrhea.
Okay, right. Recent history of vomiting, diarrhea, considering a bacterial GI infection like salmonella or even Shigella infection. Okay, good.
Upper respiratory tract infection.
Sorry?
Upper respiratory tract infection feature.
Can you be more specific regarding the upper respiratory tract infection? What sort of infection you really want to find out?
Sore throat.
Yeah, pharyngitis. Thinking of which organism?
Viral organisms.
Okay, I mean, you consider viral post-infective, like EBV, cytomegalovirus are possible, right? Any important bacterial pathogen that can cause post-infective arthritis following pharyngitis?
Group A streptococcus.
Yes, group A beta hemolytic streptococcus, right? Streptococcus pyogenes. So it's important to find out because streptococcal infections are quite prevalent. It's the same organism that leads to rheumatic fever as well. But it can cause post-infective polyarthritis alone without affecting the heart or, causing rheumatic fever. So there are two entities. So it's important to find out whether she had pharyngitis, right? Good. Okay. Then acute rheumatic fever, again, it's the pharyngitis that you're going to ask about. And regarding any acute infection, right? Like contact history, and also for infective endocarditis, whether she had any past history of rheumatic fever is important to find out, right? And also in your systemic inquiry, you need to find out whether she has any associated symptoms of acute rheumatic fever, like features of carditis like chest pain, palpitations, right? So, and any appearance of skin rashes, you could ask. And regarding autoimmune disorders, right? Considering SLE, you know what to ask, like appearance of oral ulcers, recent hair loss, weight loss, right? So all those things are important to find out. Then regarding a malignancy, again, it's very vague. So the presence of, weight loss over the past 1 or 2 months, and you basically depend on your examination findings to exclude the malignancy, but you can ask about general fatigue and malaise and things like that, right? Okay. Then after your, once you take a thorough history, before going into your examination, you can still narrow down your differential diagnosis. Right? If there was a migratory type of arthritis, you may consider more in favor of rheumatic fever. But if she had recent hair loss or oral ulcers, you may consider more in favor of a systemic lupus erythematosus. And so likewise, when you start examining this child, you will have a narrowed down differential diagnosis, right? So the general examination is extremely important in this child because there are so many clinical features that you can elicit in favor of your possible diagnosis, right? Okay. So I will go through some important things that you need to examine if you come across a child with fever and polyarthritis. So it's important that you look for peripheral features of acute rheumatic fever. Right? So can one tell me peripheral features of acute rheumatic fever?
Migrating arthritis.
Okay. So that you elicit from your history, right? But when you examine also, if there is polyarthritis, then acute rheumatic fever is unlikely, isn't it? If multiple joints are involved at the same time, it's a bit unlikely to be acute rheumatic fever, right? Okay. Fine. So stigmata of infective endocarditis. So I'm sure you already know what are the peripheral stigmata. So there is a whole list like splinter hemorrhages, Osler nodes, are features of infective endocarditis. And then features of SLE like oral ulcers, we have already talked about that. Skin rashes, photosensitive skin rashes, the malar rash and so on. And then features of dermatomyositis. Right? So dermatomyositis can present at any age, can present in adolescence. They also present with polyarthritis, but apart from that, they have many other manifestations. Like they have a typical skin rash, which affects the knuckles and extends aspects of joints. I hope you all have heard about the Gottron papules, nail bed vasculitis, and the heliotrope rash over the upper eyelids, right? So you need to look for those things in your general examination. And finally, you need to look for features of malignancy like palatal petechiae, bone tenderness as well. So that's about the general examination. Right? And the most important system in this child to examine next would be the musculoskeletal examination. Right? So there are two ways of presenting in your long case presentation. Either you can present in the order of CVS, respiratory, abdomen, CNS, and then musculoskeletal, or you may start with your musculoskeletal examination and then move on with CVS, respiratory in that order. Right? I would prefer presenting the relevant system first. Now, since this is a fever with polyarthritis, I would prefer if somebody starts off with the musculoskeletal examination. So you may start off with the gait of the child. If the child is able to walk, right, then you can see how incapacitated the child is. But however, if the child is in pain and she's reluctant to walk, never get the child to walk, you can mention it to the examiner that the child is reluctant to walk because of the pain. So describe each and every affected joint, starting with your large joints. Present the findings of acute inflammation like redness, warmth, tenderness, and the limited range of movement, right? And then describe the small joints in a similar way, right? And examine the TMJs as well. Okay. And at the same time, if you think in terms of rheumatoid arthritis, you need to see whether there is associated enthesitis, right? It could be enthesitis related arthropathy. So how you find out whether there is enthesitis is there will be swelling over the dorsum, right? Back of the ankle and in behind the knee joints. Right? Because those are the places where children show features of enthesitis. And it's important that you find out whether she has associated myositis or myopathy, right? Because this could be dermatomyositis and polymyositis. And even with SLE, there could be certain degree of myositis and myopathy, right? So check for muscle tenderness, and you can inquire about proximal myopathy as well. So if there is proximal myopathy, what could be the limitation in her mobility? It's climbing stairs, right? So you could ask that from the child. And also it's important to examine the neck and the back for cervical spine involvement and sacroiliitis. Right? So that completes your musculoskeletal examination. So the most important system is musculoskeletal system examination in this child. And by now you can further narrow down your differential diagnosis by the, when you move on to the other systems, right? So at this point, you may think the most important system to examine next is the cardiovascular system, right? Or you may think it's the abdomen, right? Right. So I thought not to give any slides on the other system examination. We could rather, talk about them. Now, in cardiovascular system, what are the important things that you need to pay attention to? The presence of cardiac murmur, whether there is any tachycardia, right? And then the blood pressure, right? So cardiac murmur is important in the point of view of rheumatic fever, and hypertension is important if you consider SLE. Right? Abdomen is relevant because in any systemic condition, there could be hepatosplenomegaly. Even with an acute infection, there could be like EBV, post-infective, still there could be remaining hepatosplenomegaly, and even in a malignancy. Right. Okay. Right. So I'm not going to discuss about the rest of the system examination. Right. So now at the end of your history taking and examination, right, now I will tell you about this patient's actual history and examination. Now, I mentioned to you already that she presented with this short history of fever and multiple joint involvement. Now, there is a history of upper respiratory symptoms about 3 weeks back, for which she has taken some GP treatment, but there is no clear-cut history of sore throat in her. There is no history of weight loss, oral ulcers, or hair loss. And the past history also, it's unremarkable. She hasn't had any previous hospital admissions for any illness. Examination, both her ankle joints show evidence of arthritis, and also her right thumb, and she also has right or left TMJ inflammation as well. She couldn't open her mouth, and she couldn't eat and drink. So actually she was quite dehydrated on admission due to poor oral intake. And the rest of the examination, CVS examination was normal with no cardiac murmurs. Her blood pressure was normal, and she didn't have any lymphadenopathy. And the abdominal examination didn't reveal any hepatosplenomegaly. So the rest of the musculoskeletal examination, she didn't have any evidence of muscle tenderness, and her cervical spine and the sacroiliac region examination were also normal, right? So now you have that information with you. Now, can you think of likely, can you narrow down your differential diagnosis now? Now, out of the list that we considered earlier, we had about 5 or 6 possibilities. What is likely now? Could this be a reactive arthritis?
Unlikely because she doesn't have sore throat.
Okay, right. Could this be then an autoimmune condition like JIA or SLE?
Cannot be SLE, madam, because she doesn't have any ulcers.
Okay, yeah, by the looks of it, I mean, yeah, at the moment, since she doesn't have those things, we may not consider, but she may evolve into the full illness with time. So still we can't say, right? So we may still consider that symptoms may take time to evolve, right? Okay. So what basic investigations would you do? Right. Okay. So what are the things now we consider? Reactive arthritis. Anybody would like to consider reactive arthritis? One student didn't want to consider because there is no clear-cut history of sore throat. But anybody who would like, still to consider reactive arthritis?
It could be post-infectious reactive arthritis, madam, because the patient has given the history of signs of features of upper respiratory tract infection, though there's no sore throat,
yeah,
clear-cut sore throat. She might be having post-infectious.
Exactly. Yeah. Yes, very good. Because it is not only the pharyngitis. I mean, pharyngitis is important if we think in terms of rheumatic fever, but any other infection may be just a viral infection without any pharyngitis, right? So, reactive arthritis is the commonest cause for fever and polyarthritis in children. So, we may take it as one of the possibilities in this case as well. Right? And we'll still keep our autoimmune conditions in our mind because the illness may be still evolving. Right? And we may, do you like to consider an acute infection also in this child? We don't have any evidence of infective endocarditis at the moment. And she doesn't have any skin rash. Okay, so I suggest that we still could consider because we haven't investigated her yet, right? So we may keep that in our minds as well. Is rheumatic fever possible in this child? I think it's unlikely because now we established there is TMJ involvement, which is not described in rheumatic fever, right? So we may not consider rheumatic fever at the moment. Okay. Malignancy, again, we didn't find anything in favor of a malignancy. So we may keep that in the back of our minds, but it is not in high in our list. Right? So we'll consider post-infective arthritis, acute infection with polyarthritis, and any autoimmune condition. Right? Okay. Now, how are you going to investigate this patient? So what generally would an examiner ask is, if you are the house officer admitting this child, what basic investigations would you do, and give your answer with the explanations as to why you do them. You may start with your first line investigations, right? Or basic. Yeah.
Full blood count for recent infection. Right. Full blood count is done.
Right, good. So your first thing will be to do a full blood count where you can find out whether there is any evidence of recent bacterial infection or a viral infection. If it was a recent bacterial, like streptococcal infection or salmonella infection, you will see neutrophil leukocytosis. Whereas it was an infection like EBV or cytomegalovirus, you will see a depressed white cell count. So that is how a full blood count would help you. Now, what else would you do? Okay, so you will do a full blood count and you will have to do a blood culture because you need to exclude infective endocarditis, a CRP to see whether there is any evidence of acute infection, ESR to see whether there is, it's an inflammatory marker as well as an indicator of possibility of autoimmune disease, and a blood picture, especially if you consider EBV infection and also in view of excluding malignancy, a blood picture would be helpful. A UFR, in SLE, you will see hematuria, and also in infections like, certain acute infections have multisystem involvement. The best example is mycoplasma infection. You might see hematuria, right? So a UFR is going to be helpful in this patient. And also, if you still consider rheumatic fever, you may do an ECG. It's not a must. Right? Okay, so these are the basic investigations that you would perform in this patient. Anything else you would like to suggest? Okay, right. So I will tell you about this child. She had a neutrophil leukocytosis. Her total white cell count was around 22,000 with 70% neutrophils. She had a CRP of somewhere around 90 to 100 and an ESR of 80, right? Her blood picture showed neutrophil leukocytosis, but nothing else. Her UFR was normal and her ECG was also normal, right? Okay. Now, in summary, now this child has a short history of fever with polyarthritis, large, small anti-MJ involvement. So she has a neutrophil leukocytosis. She has high CRP, high ESR. Okay. So can you rule out any of your differential diagnoses that we have been considering so far? Post-infective arthritis, acute infection with arthritis, and autoimmune disease. I think we still can't differentiate between all that until we do further investigations, right? So we now have to move on to our second line investigations to narrow down the diagnosis. So can you all suggest the most important second line investigations?
ANA and dsDNA to exclude SLD.
Okay, I agree with ANA. Now, we don't do ANA and dsDNA together because dsDNA is usually done only if the ANA is positive, right? So we'll first do the ANA, right? So I agree with you. Very good. What are the other investigations you would do? Do you want to do now consider each diagnosis right now? One considered SLE and want to do ANA. Fine. So that's good. And also considering SLE, anything else that you would like to do? Any other investigation apart from ANA? Anybody else? We have done a UFR, but you may do something else, another non-invasive investigation to assess the renal system.
Serum creatinine.
Very good. Yeah, the renal functions and also ultrasound scan, right? You can look at the kidneys. Okay, right. So that's about SLE, right? Now thinking in terms of post-infective arthritis, what investigations would you like to do?
Serum ASOT levels, madam.
Okay, very good. ASO titer you can do. Right. You can do EBV serology as well, because it could be infectious mononucleosis. Now it can't be a GI infection because she didn't have any GI manifestations. So we don't have to do SATs, I think, right? But one may decide to do. Okay, thinking in terms of an acute infection. So the acute infections we considered are the infective endocarditis, mycoplasma infection, and typhus. So what investigations would you do? Now we have done a blood culture, but that's not adequate. Anything else?
Echocardiogram.
Yes, very good. So you have to do 2D echocardiogram. You need to see whether there is any vegetations, right? Okay, 2D echocardiogram and mycoplasma antibody titer, and also rickettsial antibodies. Now, rickettsial infections can present without a skin rash, right? They can present as continued fevers, right? Polyarthritis. So, if the patient is from a susceptible area where typhus fever is prevalent, you may do a rickettsial antibody titer, right? Okay. Those are the second line investigations, right? So 2D echocardiogram, ASO titer, ANA, EBV serology, mycoplasma antibodies, rickettsial, USS abdomen, KUB, and the renal functions. Okay, right. So we did all that in this child. Her 2D echocardiogram twice was normal. Her ASO titer was 1200. Her ANA was negative. EBV serology negative. Mycoplasma antibody titer we couldn't do because it was not available. Rickettsial antibodies negative, and ultrasound abdomen KUB didn't show any renal involvement. Okay, right. So what do you think now?
SLE is unlikely according to the investigations.
Okay, right. So SLE unlikely. But we generally, yeah, I agree with you. But however, with one negative ANA, we may not exclude SLE, but we can say it's unlikely. Yeah, good. Okay. But we may repeat the ANA if she, evolves her symptoms, right? This may be a too early ANA to detect, right? Okay. Okay. So now with what is possible now?
The ASOT titers are more than 1200, which is the upper level is taken as 200, madam. So it's very much elevated, so that it could be due to a post-streptococcal.
Yeah, very good. Yeah, it's very high, isn't it? It's 200 is the upper limit. Now this girl's ASO titer is 1200. Yeah, so it's likely. Okay, so the third line investigations. Now these are the things that you may do. We haven't done any of these things, but one student actually suggested doing ANA and DSDNA. So this is the way you plan. You first do your basic investigations, and then we do our second line investigations. And now we have got a very high ASO titer, but before that, we plan ahead. If we don't get anything positive with our second line, we'll go ahead with these third line investigations, right? So, however, since we have a negative ANA, we don't have to proceed with the DSDNA. But however, these are the ones that we might do later on if she continues to have her symptoms. The DSDNA, X-ray of the joints to see features of rheumatoid arthritis, and further autoimmune screen for dermatomyositis, polymyositis, and things like that. And also bone marrow, if we think in terms of a malignancy. So that is the way forward. But we didn't have to move beyond this because we could end up here because we got a positive result. And we repeated this in 1 week time. and it's 1,400, right? Okay. Okay, so we, finally arrived at our diagnosis as post-streptococcal reactive arthritis. So in post-streptococcal, now group A beta hemolytic streptococcus is a very nasty organism. It can cause an array of diseases in children, starting with pharyngitis, tonsillitis, right? And acutely scarlet fever in young children. Right? Scarlet fever again is a very severe infection where they develop this classic skin rash with polyarthritis, lymphadenopathy, right? The strawberry tongue and all that. And then as post-infective phenomena, they can give rise to acute rheumatic fever, right? With rheumatic carditis and all the morbidity and mortality. Then it can also give rise to post-infective polyarthritis like the one our patient had. It also can lead to various post-infective neurological phenomena, like chorea, and also it can lead to various tic disorders. Right. So this is one of the sequelae of streptococcal infections. So how are we going to manage this patient? Now, she has been harboring streptococcal infection in her throat, right? So that is why she had some upper respiratory symptoms. So we need to do eradication treatment for this girl. So how do we eradicate the streptococci in the throat? Is by penicillin 10-day course, oral penicillin for 10 days, or you can use intravenous penicillin or intravenous cefotaxime. So any antibiotic is fine, but basically it's oral penicillin for 10 days. And she needs a lot of supportive care because she was in pain due to, mostly due to the TMJ involvement. She couldn't eat and drink. She was dehydrated, right? So she needs rehydration, maybe initially with intravenous fluids, and then using a straw to drink rather than, moving her jaw too much. And then she will need adequate pain relief. Right? So what sort of a pain relief we can use? So until we confirm our diagnosis, we are unable to give NSAIDs because it can mask our diagnosis. Say if it's a rheumatoid arthritis, it will mask our diagnosis if we start NSAIDs early. So the best analgesics to start with initially would be regular paracetamol or Panadine with intermittent use of ibuprofen. Right? Okay, and she will need adequate bed rest and splinting of the painful joints to limit the joint movements. So those are the supportive treatment, and the specific treatment would include then until when we diagnose the condition, we can start on aspirin. Right? So she was commenced on aspirin treatment. The dose is between 50 to 70 milligrams. So that is the range. So she was commenced on aspirin and she steadily responded to the treatment. So what is the long-term management? So the acute management is that you give supportive care and then specific treatment with aspirin and streptococcal eradication treatment. Now the recommendation for post-streptococcal polyarthritis is to prevent recurrent streptococcal infections. We have to put these children on 1 year of penicillin prophylaxis, because the next time she has a possibility of developing rheumatic fever, isn't it? This time, luckily, she developed post-infective reactive arthritis, but the next time it could be rheumatic fever. So to prevent that, the guidelines recommend to put them on prophylaxis for at least 1 year. Right. Okay. So that's about this case. Actually, it's an interesting case. So there are so many possibilities that you need to think of, right, and rule out by your good history taking examination and with your basic investigations, right? So I think you grasped how we evaluated this child and arrived at the diagnosis. Now, I forgot to mention about her throat culture. Throat swab also was positive for group A beta hemolytic streptococci. So we have basically confirmed that she is harboring streptococcal infection, and now we have eradicated. Now today we have completed the 10-day course of oral penicillin, and today she received 1 dose of benzathine penicillin. Right, so ready for home today. So she will be put on monthly benzathine penicillin prophylaxis for 1 year. Why we are not giving 3 weeklies? She was not a case of acute rheumatic fever. If she had rheumatic fever, then it would be 3 weekly prophylaxis. Okay, right. So that's about the case. Any questions before we move on?
Madam, can she have mild acute rheumatic fever without any symptoms?
Yeah. Now, the problem is acute rheumatic fever, usually there is no TMJ involvement, which is unlikely, but it happens in post-infective arthritis. So TMJ involvement is not a feature of rheumatic arthritis. Now we have diagnostic criteria. So that was actually what I'm going to discuss next. Right? We have major criteria, minor criteria, and supportive evidence. Right? So we arrive at the diagnosis of acute rheumatic fever based on the criteria. Right? And it's clearly distinguished between the rheumatic arthritis and post-infective arthritis with this presence of dactylitis and TMJ involvement. Even dactylitis is not described in rheumatic. Okay, so that's why we didn't consider acute rheumatic fever without carditis. Okay.
Okay.
Right. So I would like you all to go through, do some homework, read about the revised Jones criteria to diagnose acute rheumatic fever. We have major criteria, minor criteria, right? And then based on these, we have to consider the laboratory features as evidence of and supportive evidence of antecedent group A streptococcal infection. Right? So considering all this, we arrive at a diagnosis of the initial attack. So we should have at least 2 major manifestations or 1 major plus 2 minor. And always we need to have recent GAS infection. Right? So if you consider our patient, she has 1 major manifestation, but the problem is there is odd joint involvement, which is not in favor of rheumatic, right? She has recent GAS infection. Okay, so that is why acute rheumatic fever is unlikely. Right, so this is about, right. Okay, so I thought I will tell you some of the questions we pose you at the long case. Now, a good student would tell the history, the examination, and summary. You need to form a good summary. In this type of straightforward cases, we usually don't ask for problems. It will be the summary. And then you have to go on telling how you are going to evaluate this patient, right? Without waiting for the examiners to ask that question from you. So, however, if you do not proceed, if you stop at your summary, then the examiner will ask you, what are your differential diagnoses as the on-call house officer or the first contact doctor. And then, after mentioning your differential diagnosis, you can go on telling how you are going to investigate. But if you don't do that, the examiner will again ask how you are going to investigate this child. So that is how I took you through the history and the case. Right? So we talked about the investigations, and then you will be questioned on how to manage this patient, and then you will be tested on your knowledge on the diagnosis of acute rheumatic fever, its management, and the long-term management. Okay, so these are the possible questions. So you need to read about the theoretical background of polyarthritis. So I would suggest you to read about the diagnosis and management of infective endocarditis, SLE in childhood, and also prevention of recurrence of rheumatic fever. Okay, so these are the important things that you need to improve around this case. Okay, so that's about it. I plan to tell you today. If you have any questions, we can discuss.
Madam,
Yeah.
regarding penicillin prophylaxis, if someone is allergic to penicillin, what can we give?
We can use erythromycin, but it's oral.
Okay, madam, thank you.
So read about rheumatic fever. I have done about rheumatic fever in my 5th lecture of CVS. By the way, have you all got the lectures uploaded to Moodle?
No, madam.
I don't know why. I have submitted all the lectures. If they haven't done, I mean, I can upload on my own. Then I will go ahead and do it myself, right? So I have the lectures with me. I'll do it today. I thought they could have done it. Okay, I'm sorry
Madam?
about that. I don't know what happened. Yeah?
Madam, in this case, X-rays, can we take it as a first line?
Not really. We don't gain much from X-rays in acute arthritis, right? So it's just the acute inflammation. But if it goes on, if we really think of adult onset rheumatoid arthritis in this child, then we can do an X-ray. Otherwise, not necessary. We do X-rays only when we suspect septic arthritis.
Thank you, ma'am.
Any other questions?
Madam, can we consider streptococcus skin infection as a cause of rheumatic fever?
No, it's a different strain. Only the pharyngeal strains cause rheumatic fever. The skin strains they are nephrogenic strains. They are not rheumatogenic, right? So the strains are different. I'm sure you all learned in microbiology about that.
There was an article saying, madam, if the patient has superimposed infection in a scabies burrow,
Yeah.
it's noted that it causes rheumatic fever after infection.
Okay,
It's
I don't
widely
know.
like,
It may be a case report, but there is no, I mean, what we have learned and what is established is that the nephrogenic strains are different, but the pharyngeal strains can cause both. They can cause both rheumatic fever and nephritis, but the strains that cause nephritis alone, but not rheumatic fever. Let me check on that. I mean, that is the theory, what is, taught. I'll find out. What is your reference?
it was from Medscape, madam.
So you have to be careful, because if that appears in an MCQ, you may get it wrong, right? So I will find that out and let you.
Okay, thank you.
Because we don't give prophylaxis to children who get recurrent impetigo. Impetigo is most also due to group-based streptococcal infections. No, it's either staph or strep. So those children, we never give. We don't bother about their skin infections, but if they cause rheumatic fever, then we have to be more careful, isn't it? Okay, we'll find out in a minute. Any other questions? Right. So what do you suggest for me to do next time? Any suggestions? Do you like case discussions like this?
Yes, madam.
So next time, would you like to do some short cases? I could video a short case and then discuss on that if you like.
Yes, ma'am.
Any other particular long case that you all would like to discuss? You could email me. Do you all have my email address?
No, madam.
Huh?
No, madam.
No? I think you all know because you all send me the essay answers for essay questions. දන්නවනේ නේද? You all are the ones who send me the answers for essay questions. No?
Yes, madam. It was there.
So you all know my email address.
Yeah.
No, short-term memory loss. Okay, right. So if you all want me to do anything particular, you all can let me know. I may be doing another class before you all begin your proper appointments. Okay.
In summary, the discussion today was focused on the diagnosis, assessment of dehydration through history and examination, fluid management, and monitoring. Diarrhea and vomiting is a common clinical scenario that a doctor would come through in pediatric practice. So therefore, these areas are important for any first contact doctor to be thorough with to prevent development of complications due to dehydration in a child with gastroenteritis. Thank you.